I'd like to introduce to you from the VA New York Harbor Healthcare System, Dr. Patrick Malloy.
Thanks, and I wanted to say a special thanks to Robert and Mary Ann for inviting me to be part of this distinguished panel this morning. The talks have been excellent, and I hope mine is up to par. Just to give you a little bit about my background, I'm an interventional radiologist. I did my training at Johns Hopkins, and I was very fortunate to work with some of the surgeons that Dr. Labuti mentioned, Dr. Cameron and his associate Dr. Pitt, and some of the pioneers in hepatobiliary work, but I've also had been fortunate to work with some of the other physicians mentioned that you've seen, Dr. Alexander at the University of Maryland, Dr. Nunning, a colleague of mine out west, who also does interventional radiologist and very much involved in metastatic neuroendocrine tumor treatment. I'm a native New Englander, so it was like Dr. Labuti. It was a big decision to whether to stay down in the Mid-Atlantic region and come back up here. But I've been back up here in New York for about 6 months now, and it's been a great thing for both myself and my family. And we're very happy to be back up here. And this morning, I'd like to talk with you about some of the new treatments that we as interventional radiologists are doing for liver-directed therapy, and in particular go over some of the details of the radioembolization procedure that I've been fortunate to be involved with over the years. Just to mention something, we as interventional radiologists have been involved with liver-directed therapy, and a lot of the work that has been done has been out of both involvement with neuroendocrine tumors, but also with metastatic colorectal and primary hepatocellular carcinoma. And we know that, as was mentioned before, that there is a rising incidence in the incidence of both primary and secondary hepatic malignancies here in the U.S., while other malignancies the incidence is going down. With yttrium-90 or radioembolization treatment, we're treating both primary tumors and metastatic tumors from a wide variety of origins, and we'll focus on our treatment with neuroendocrine tumors today. Dr. Gerstein did a very good job in outlining the origin of carcinoid tumors. In the types of tumors that we tend to treat tend to be tumors arising from the midgut. As Dr. Labuti was mentioning, approximately a third of patients will present with metastatic disease. The metastatic disease tends to be either to local lymph nodes or primarily to the liver. Now, one of the reasons why the tumors will be presenting as liver metastases is because the portal venous system is the primary drainage of these midgut tumors, and the liver acts as a primary filter for all of the blood flow coming from the midgut, and that portal venous system will then trap those cells and provide a rich environment for them to potentially grow. Here's also some of the symptomatology that was mentioned earlier from the pancreatic tumors. Again, pancreatic tumors may or may not be functioning. Those that are functioning will become clinically manifest when they metastasize to the liver, as was mentioned before, because of the fact that once they go to the liver, they will no longer have that first pass detoxification that we see with the blood flow that comes from the liver. One of the challenges we have in treating patients with metastatic neuroendocrine tumors is that the clinical course is very variable. And some patients may have very aggressive tumors. I think that was very well shown by Dr. Gerstein as the variable course with patients with highly aggressive tumors, and there may be some that are indolent. So many patients can be followed for years without interventional treatment. And again, the carcinoid symptoms patients may become first symptomatic from metastasis to the liver, or patients may need to be treated due to tumor bulk. Surgical treatment, again, was covered by Dr. Labuti, and also may be the best option in patients that are candidates. Although it may be that for classic surgical treatment, only a minority of patients may be candidates at the time of the presentation. Other potential treatments would include cryoablation or radiofrequency ablation, and those are basically for patients who have limited or focal disease. Today, I'd like to concentrate on talking about the concepts of intraarterial therapy. I've been involved in treating patients with metastatic neuroendocrine tumor with a variety of types of liver-directed therapy, both bland embolization, chemoembolization, and most recently radioembolization over the years. And it's generally indicated for progressive disease or symptom progression despite treatment. What is liver-directed therapy? Well, the liver-directed therapy is a general term we use for the direct introduction of either cells, molecules, or particles into the liver for the treatment of tumors. And there have been a number of different approaches. For example, there have been some investigators who have actually injected attenuated adenovirus into the liver and have had very good results, primarily for the treatment of GI origin cancers. Intraarterial chemotherapy has been used both as hepatic arterial perfusion and also as chemoembolization, both and particles. Chemo for both radioembolization, the injection of therapeutic radioactivity tagged particles that lodge in the liver, and we'll see a little bit more about that later in the talk. Other types of liver-directed therapy are percutaneous approaches. Percutaneous injection treatments have been given, but are largely abandoned now due to both the thermal treatments, both with radiofrequency ablation, cryoablation, microwave, and more recently with techniques of electroporation. And here's an example of a patient that I treated with metastatic neuroendocrine tumor, a focal tumor. Here you can see this was after a chemoembolization procedure where the ethiodol, the oily agent that was used to embolize or stop the blood flow in the tumor, you can see here is residual in the tumor. And there's the percutaneous radiofrequency ablation probe, which was placed, and the starburst pattern of the device there spreading out. You can see that going beyond the margins of the tumor, and as Dr. Labuti was mentioning, this can be done either percutaneously or intraoperatively. And our goal is the same: is to basically obliterate this tumor and leave a margin of tumor-free tissue in the liver. And it tends to be very, very effective for patients that have limited or focal disease. But unfortunately, a lot of patients may have multifocal disease, and most of the patients that are referred to me fall into that category. And so the techniques of embolization or chemoembolization or radioembolization have been developed. And one of the first questions is, why would that work? Why can you embolize something? Embolization is a medical term that we use that means that we're injecting particles or some substance into the arteries to stop the blood flow. Now that seems to be counterintuitive. If we put particles into the kidney to stop the blood flow, the kidney would die, and it would no longer be functional. If we put that into the brain, the same thing would happen. So why can we do that in the liver and have it work out and have it be effective? And the reason is because the liver has two distinct blood supplies, as both Dr. Gerstein and Dr. Labudi had mentioned to you. The portal vein is the vein that drains all the intestines, the pancreas, and the spleen to the liver, and that constitutes about 75% of the blood supply to the liver in normal livers. And about 25% comes from the hepatic artery, the arteries that are directly coming from the aorta. But one curious thing we find is that for tumors that metastasize to the liver, by the time that we can detect them with any type of imaging, either PET scan or CT or MRI, by the time they're actually detectable, almost 100% of their blood supply is being supplied by the hepatic artery. So we can actually stop the blood flow or temporarily stop the blood flow in the hepatic artery and selectively kill the tumor and let the liver survive. And that's the basic tenet of whether it's a bland embolization or a chemoembolization or radioembolization. That's what allows us to do that and have the patient recover. Now, some of these percentages differ whether you have a cirrhotic liver or a non-cirrhotic. Fortunately, most of the patients with metastatic neuroendocrine tumor have a non-cirrhotic liver, meaning that the liver in between the tumor tends to be relatively normal. So therefore, it will recover even faster after we do these treatments. And then the other important thing with these embolic or liver-directed therapies is that we found that the blood supply to these tumors tends to be different than the blood supply that goes to the liver. The blood supply to the tumor tends to be like an open gate, like always the tumor always wants blood, whereas the liver itself or normal organs regulate their blood flow according to what they need. They only kind of take only what they need and leave the rest. The tumor always seems to want the blood flow, and I think Dr. Labudi showed some very, very nice pictures of these tumors that they're what we call hypervascular. They always want a lot of blood flow. And so what we found is up to 19 times, when we inject particles, up to 19 times the number of particles go to the tumor as go to the normal liver. So there is a distribution that favors these particles going to the tumor, and that's another thing that really allows us to treat these tumors effectively. So how is this done? Well, here's a patient where we were treating the tumor, and you can see here's the catheter. It's placed in just in the same way that a cardiologist would do a cardiac catheterization. This is basically like a liver catheterization, where a small catheter tube is put into the artery going to the liver, and you can see here there's some blotchiness here from this tumor. There's some little patchy blotchiness here that really is different than the normal liver perfusion. That's what we're targeting. And you can see here in the later phase, it fills in here, and then some early filling of the hepatic vein, and that's the typical thing that we see. This large regional area that's all tumor. Now that was deemed too large and regional for either ablative therapy or for or for surgery, and therefore was sent for a regional or liver-directed therapy. Now, when we're evaluating a patient for a radioembolization procedure, what are the things that we look for? Well, first of all, we want to make sure that they're not a candidate to be resected, because, as Dr. Labudi pointed out, if we can do resection, that would be preferred to start off with. So we look at the distribution of liver disease. Is it focal, or is it involve both the lobes of the liver in a multifocal distribution? Is there a very active extrahepatic disease? And what the anatomy is to the liver arteries, because the liver arteries themselves, there is a pattern we call a classic anatomy, but only about 25% of patients really have the typical or common or classic anatomy. Most of us in this room will have some variation in our anatomy to the liver arteries that's different from the other, and that can make a big difference when we're trying to make plans for these types of treatments. And how overall is the patient doing, their performance status, their liver and kidney function. And in some of the studies, one here, something relative recently shows that really the most important things that we look for in selecting patients for liver-directed therapy, or particularly for chemoembolization and radioembolization, is their performance status, how much tumor is in the liver. We found that patients that have over 50% replacement of the liver by tumor in general tend to have a higher risk than patients that are less than 50%. Although there is a caveat to that. This is all comers. Patients with neuroendocrine tumor. There's been some more recent tumor studies that show that patients even up to 75% can have these procedures done effectively. And the serum bilirubin, serum bile level, tends to be a very important prognostic indicator. Again, we evaluate a patient for resectability, and we look for the extent and distribution of liver disease. And again, that overall, patients over 50% tend to have a slightly higher risk for these types of treatments. So just to summarize, in selecting patients, one of the probably the most important thing that I look for when I first see a patient is what their performance status. How are they doing? Are they able to do their activities of daily living? Are they able to care for themselves independently? And how much assistance they need? That's probably the most important factor. And then again, their bile level, whether the portal vein is patent, and some blood tests that are indicative of overall liver function. Whether the metastatic disease is confined to the liver, or if there is extrahepatic disease that is progressive, that could be a potential contraindication to treatment. Portal vein thrombosis or clotting of the vein going up to the liver was thought initially to be a contraindication, but it is no longer, and we will treat patients with that, and that's been borne out in some of the past literature. The other things that impact our patient selection for radioembolization are patients that have had prior radiation, either or have greater than 20% lung shunting. There is the potential when you inject particles into the liver that some can actually pass through the liver and go to the lung through the hepatic venous drainage. And we do tests for that prior to these treatment, just to make sure that the patient will not have radiation toxicity to the lung as a result of the treatment. Some of the things just with regard to this treatment itself, the embolization sphere is a resin sphere. It's labeled with a radionuclide called yttrium-90, And I'll go over some of that right here. The particles themselves are very, very small. They're 30 microns, just a fraction of a millimeter. And why is that? Well, multiple studies have been done to look at the optimal size of particles that distribute themselves to tumors. And it's been found that these very small particles, less than 50 microns, are most optimally distribute themselves with that tumor vascularity that I told you before, so that we get a non-uniform distribution of these particles that preferentially go to the tumor vascularity. And that's been and so it gives a very high dose of whatever we're trying to deliver to the tumor, and again, it spares the normal liver. There are two major types on the market now for yttrium-90 labeled microspheres. There's the glass spheres, thyrospheres, and the resin spheres, spheres that you'll see. They're both labeled with yttrium-90, and yttrium-90 it's bound to that sphere. And one of the common misconceptions about this type of treatment is that it's not like a diagnostic nuclear medicine scan where you may be injected with a radionuclide, but then it circulates around in your body and it can be excreted in the urine, for example. This is a therapeutic dose of radiation that's bound to the sphere, either the glass sphere or the resin sphere, and when it lodges in the liver, it stays there, and it exerts its effect. It only travels about 2.5 millimeters around where it lodges, but there are millions of these spheres that are injected into the tumor, and again, they distribute themselves around in the tumor vascularity. Their effect is only about 2.5 millimeters, but the net effect of that distribution provides a very potent radiation dose to the tumor, and is very effective at treating the tumor in which is injected. The other important point of that is that once it's injected, there's very little primary radiation that is transmitted outside your body to other people. So it's a very safe. Patients generally have this done and go home the same day, which is a very important and an advantageous part of the treatment. Again, they're permanent embolic agents, and only a very small part of the activity leaches out of the sphere. One of the things that is done to evaluate patients prior to having this type of treatment is to look for is to take a look at your hepatic arterial anatomy, and this is the typical anatomy we see in patients. This is one of the arteries going to the stomach, the gastroduodenal artery. There are other arteries coming off here that typically go to the stomach. As Dr. Labudi was mentioning, in the surgical operation, when they do isolated liver perfusion, they'll isolate these branches to make sure that everything goes to the liver. The interventional radiologist will do a similar thing when they prepare a patient for a treatment such as this. What they'll do is they'll do what they'll call a protective embolization of the branches of the liver artery that go to the intestines, such that all of the injected material will go to the tumor and not to the intestines, because if it were to do that, it could cause radiation complications to either the pancreas or to the stomach, which we certainly want to involve. The other important thing about this type of treatment is that we will tend to do what's called a lobar treatment. And what that means is that the liver is generally divided up into two lobes. And you can see this patient has these tumors here, mostly in the right lobe, but there also is a larger tumor here in the left lobe. And the arterial supply is generally, the major division is between the right liver artery and the left. And so what we tend to do is we tend to treat one lobe at a time. Initially, the initial studies done with both chemoembolization and radioembolization were done as a single liver injection. And those tended to be have higher complications because not only from patients having a longer time for recovery because of nausea and abdominal pain, but also a higher incidence of extrahepatic radiation effects because the materials were injected from closer here on the liver artery. When we go out more distally, more selectively into the arteries in the liver, we can more effectively control the way that these particles are delivered, and the recovery time is much shorter, and the post-procedural symptoms are very much reduced. And in fact, because of the hypervascularity or the high degree of blood flow that in patients with neuroendocrine tumor, the tumors tend to really act like sponges for these particles. And most of the patients with neuroendocrine tumors have very, very, very little post-procedural symptomatology, which is actually slightly different than what we see for our patients with metastatic colorectal cancer, because their tumor vascularity is not quite as robust. And you can see there's a number of, here's a patient, like I said, we embolized, here's this protective embolization where these little coils are placed to block off this blood vessel going into the intestine that allows all the particles to go up where we want them to. And a number of different pictures to show you that these are different ways in which the liver is supplied. Here's where a liver artery, it comes off the same artery that goes to the intestines. Again, there are, it's just to point out that there are a lot of different ways in which the liver can be supplied. And through the experience over the years, most patients, it used to be thought that there were some types of patients with different variations of their anatomy which could not be treated. However, that is very rare. Most patients, there are different ways that these vessels can be catheterized and patients can be effectively treated. And this is just, again, a number of different variations on anatomy. And I'm going to skip forward a little bit here just to show you. This is a patient where the entire blood supply to the left side of the liver was also shared with the stomach, and that could have been something that precluded the patient being treated. This was a patient of mine where we actually went up and selectively went into each one of these branches, blocked them off, and then we were able to successfully complete the treatment. And a number of, again, here's a number of similar examples. And here's just, this is an example of a patient of mine that we treated in contradistinction to that patient that had that focal tumor here. You can see this, there is tumor throughout the entire liver here that, and this was, and this patient underwent successful treatment. Another example of tumor here, both up in the upper part of the liver and the lower part. This entire segment of the liver will be treated in one session, and then this segment of the liver will be treated in a separate session. And I'm going to flip forward just because I want to go over some of the technical details. Prior to the treatment, the patient will be evaluated for, like I said, for shunting to the liver. We do a test injection of macroaggregated albumin, which is basically like a protein that is injected, and we look for how much of that goes through the liver and goes to the lung. Here's a picture. Here's a picture of that showing that again, this is the liver here, and you can see the distribution of these particles. This is what we do ahead of time as a test injection to make sure that the particles are going to go where they're supposed to go. We then calculate how much goes to the liver, how much goes to the lung. You can see very little here to the lung. Almost all of them go into the liver. And this patient underwent a successful treatment. Generally, these procedures are done as an outpatient. The patient comes in on the day of the procedure, has some routine medications that are given ahead of time, and the procedure is done in the angiographic suite. Here's the special delivery device that is used to deliver the particles. It takes a little bit of time to set up, and again, as Dr. Labuti had mentioned with the isolated liver perfusion, it's a little bit complex, but once it's put together, the treatment itself is very short. It's only about 40 minutes. Here we are about to give the procedure, the treatment. We have monitoring equipment in the room to make sure that the dose is correct. Here's the dose being delivered. There it is here in this vial. You can see here's the spheres right there. They're actually down at the bottom of the vial right here. What we do is we put these special needles in here, and then we suspend them up and inject them in small aliquots, and we monitor the perfusion to the liver during the entire time. Here's the dose of spheres right here, and with my associate, and then afterwards, after the treatment is done, we do another quality control. We can see we expect it to go here. This is the liver right here. We expect this to go just to the liver. Here it is to the targeted right liver. Some patients may have some mild degree of pain post-procedure, but that tends to be very, very short-lived, and most patients are just discharged 2 or 3 hours after the procedure for routine follow-up. The adverse events, the most common things that we see after the procedure are patients developing what's called post-embolization syndrome. And post-embolization syndrome tends to be a triad of fever, generalized malaise, and in the situation of a hepatic embolization, some degree of right upper quadrant pain, which is generally relieved by just routine non-steroidal anti-inflammatory drugs. In properly selected patients, the overall complications have been very, very low. Some of the things that we're worried about is what's called non-target embolization. If any of these particles actually go into the gastrointestinal tract, they can cause radiation-induced ulcers, which can be quite severe, and they can cause acute pancreatitis or radiation cholecystitis, and that's why this is the procedures are done as a two-step procedure where the patient will come in ahead of time, have a picture of their liver arteries done, and then have that protective embolization procedure done to ensure again that the particles go to the proper place. Radiation pneumonitis is very, very, very low incidence. Again, we mentioned that the particles can go through the liver and then go up to the lung, but that's what's assessed by that shunt study on the initial visit. And any patient that has a 20% or higher shunt is excluded from the procedure. It's also possible that patients after the procedure can develop some degree of liver dysfunction or portal hypertension. But again, that has been very isolated and very, very low incidence. The results that we've been seeing with this procedure have been very, very good. I think both in they've paralleled or sometimes better than the results of chemoembolization that we've seen, as Dr. Labudi mentioned. We can see up to a median survival of 30 months, depending on the patients that, again, the type of disease and the activity of disease. Many of the patients that are referred for these procedures are of advanced stage, and even with patients with advanced disease with a high degree of replacement of the liver, we are still seeing significant responses, and that's been borne out by some recent studies as well. I think we're seeing some promising news coming out of Europe, and I think they're a little bit ahead of us in their application of these liver-directed therapies. But in the future, I think that our challenges are to further refine our techniques for selecting patients, but also how do we integrate this therapy into both the oncologic and surgical therapies in a diverse population of patients who have a varying manifestations of disease and varying activity, and I think that's our challenges for the future. So with that, I think I'll finish up, and I thank you very much.